Thanks to the diehards for staying till the end. Anyway, I had the privilege and the opportunity to talk to you about the more technical part of the hip-related problems when we consider surgery. So it's a privilege to finish this session by technical means. So this might be a rehearsal for the people that were there at the talk of Dr. Schilders yesterday. So which team is this? Thank you. You listened very well. I couldn't leave it like that, I'm sorry. So I would like to introduce a little bit my talk, stating that we'll have a little word on the differential diagnosis of groin pain regarding hip-related pathology. We'll do a diagnostic setup, how we as surgeons do this setup. We'll talk about some indications for surgery, some surgical cases, how we consider the rehab, what we see as the results, and the complications. So I hope this interesting 2 days conference where the world of groin pain has been put together very beautifully enlightened us very much on the subject, but still we can be flooded by different disease entities in groin pain, of which the hip is only one of them, but probably a very important one, in my opinion, and probably also a long time neglected one in this spectrum of groin pain. So after the fantastic presentations of Paolo Golano, we all know the anatomy now very well, but I would like to introduce you how we as surgeons refer to the hip nowadays. And I would like to show you how we think about the hip compartment, because we think the hip is the hip, it's a ball and socket joint, that's it. But as surgeons, we look at it in 4 compartments nowadays. We talk about the central compartment, the peripheral compartment, the lateral compartment, and what we tend to call for the moment the 4th compartment. And I'll round up with you these 4 compartments, if that's fine. Now, the central compartment is mainly about the femoral head, the acetabulum, and you can see loose bodies, synovitis, and of course we consider the cartilage, the teres ruptures, the labral tears, and the impingements. Now, I'm not going to talk about the chondropathy, the mild, none, or a major chondropathy, because of course that's still an issue. And we know as surgeons that even for knees, and the hip is coming later, we don't go for hip arthroscopy to alter chondropathy signs. But of course the synovitis is something that we treat with the nettoyage anyway. We'll mainly focus on these labral tears and this mechanical dysfunction from the bony impingement onto the acetabulum. Okay, acetabular labral tears, they present in 22 to 55% of individuals with groin pain. So in our treatment nowadays, just like with the meniscus in the knee surgery, we are doing everything we can and able to protect and preserve the labrum. And here you can see just an image of a synovitis inflammation around this labral tear on the superolateral part. And this is an acute one in a way. You can also have this elastine into the labrum itself, this yellowish morphology, showing that you have a chronic overload on the structures with the inflammation around it. Sometimes you need a probe to really visualize the type of injury, so it's not always obvious entering into the joint. Now, just to show you, I wanted to highlight with some minor clips how you see it when you enter the joint. So this is the femoral head, this is the acetabulum, this is the fovea, and we're entering with our shaver just to give us some visualization of the central compartment we're talking about. And here you can see the labrum that is not anymore attached in a very well fashion to the rim. So you see some inflammation there. There we go. In order to do some labral fixation, we do some acetabular rim trimming, we remove the debris around it, and then after the rim trimming, we go with our suture underneath, just into that interval, in order to refix the interval itself. You can also see that when we hit on the labral tear, or we probed it, that you can have this wave sign of cartilage delamination around it. This is very typical. Now, a little bit further we go. So the suture is now around it. And then what do? We make it nice and tight. There are many different ways of suturing it, but I just show you how we do it. And then we drill into the acetabular rim towards the bone itself. We make sure the anchor is in well positioned. And then We tap it into the bone, nice and deep into that bony area. This is the anchor going into the bone just behind the labral structures. We check if it's okay, we tap it in completely. And then you see where it's detached here. You can see once we fixed it in a proper fashion, then it's stabilized again. Okay. So, one of the most rewarding problems for hip arthroscopy surgeons to treat is chondromatosis. Of course, we always talk about cam impingement, pincer, labral tears, but we tend to encounter frequently this chondromatosis. And once you've removed the locking cause in that hip, people are immediately relieved by their pain. And sometimes this presentation of chondromatosis can be spectacular, though, but sometimes difficult technically to remove. This is just one loose body that you can remove, but sometimes in the peripheral compartment, it's a bunch of them. And it looks like, okay, you remove it, finish, but our trocars, which are the plastic tools in order to enter the hip, the ones we use here are like 8mm diameter. These diameters are much more. So you're there, you can see them, you have your trocars in place, everything's there, but how do you remove them? So we had to use abdominal trocars in order to remove them. So these are just little things, but that makes the challenge and the pioneer work in hip arthroscopy so nice, in my humble opinion. Now, that was the central compartment. How about the peripheral compartment? That's the one we tended to talk about this afternoon extensively, with very nice different visions on that. Now, the main indications are synovitis, loose bodies, and the cam impingement. And we already stated that for cam impingement, our clinical assessment mainly focuses on this flexion, adduction, internal rotation that triggers the cam pain. When we go for the posterior side, there's also this posterior impingement possibility. Well, that's the opposite. We put the patient in extension of the hip, and we give external rotation, and that triggers the posterior impingement. To give you an idea on how we do the cam assessment, so here you see the left hip of our athlete. We go in external rotation, and this seems pretty obvious. Look at the endorotation, which is pretty limited. Now we go to the other hip, external rotation, no pain. And this is what we call a normal endorotation. So clinically, it's a basic assessment, but it gives you a very good idea on how this presentation is. Now, as surgeons, we like to keep it simple. Less endorotation, impact supporter. Groin pain syndrome, as a combination, has a high suspicion for femoral acetabular impingement. But what we also use frequently is the C sign. You just put the C on the groin itself and on the back, and patients tend to localize these two areas, these two spots around their hip as the painful ones, the C sign. Now for me, this is the summary. This is how cam impingement is. You have the acetabulum, you have the femoral head, and there's just something in between that is really annoying. Now, I'm going to run over quickly on this rather little theoretical part because we already focused very well on that. Just to say that this angle that we use of 50 degrees, a Swiss radiographic group, Situ Rutter, I think, says we have to look at an angle more towards 55, 60 degrees, but in my opinion, it's more a radiological debate than a very sports physician surgical debate. The crossover sign is very well known, and we discussed already the mechanism of injury extensively. Maybe in summary, I can show you this video of what FAI really does into the hip. It's a mechanical hip disorder defined as an abnormal contact between the anterior acetabular rim and the proximal femoral neck. That's the impingement. And it's a rather recent known cause of hip pain and possible cause of coxarthrosis later. It was already said by Professor Leunig, the pistol grip deformity is very common and first shown by Stuhlberg, and this can help us in our basic assessment to have a good idea on what's happening. You have this cascade of problems. You have the bony impingement, you have the labral tear, the delamination towards the cartilage that really delaminates further centrally. And that's where the chondropathy gets its place then, and that's what we all want and have to avoid, of course. Now, how about treatment? The hip dislocation with the open osteochondroplasty was first introduced by Gans, who described the concept and the treatment of FAI for the first time. Now, in recent years, FAI is mainly treated arthroscopically, although there's still very limited literature to state or to compare both techniques. What we do know is that the clinical results are the same as already stated, but really much more data is needed to say, do we go conservative, do we go arthroscopically or open? Now, maybe we just run over quickly the arthroscopic way of treating it, because that's where my experience is in. You have the open technique with the dislocation. Of course, like Professor Linnick said, you just have to be very familiar with the techniques that you use. Is it open or not? The question is still open, what is the best? But if you feel comfortable with it, your results are good, just go for it, would be my opinion. Now, this is just about the peripheral compartment. This can be called a bump, a bony bump that really interferes with your mechanical movement in the hip. This is the femoral neck. You have the femoral head here with the acetabulum. We were in the peripheral compartment. When we remove the piece of bone, this is how it looks like. And then when you go to look from the other side, you can really see that the motion is freed. The question is how much bone to take away. Now, Mardonis and his group showed that you can remove up to about 30% of the femoral neck, which in my opinion is quite a lot, without risking a fracture or alteration the weight capacity of that femoral neck. This is how it looks like on X-ray. So you have your cam impingement, and this is how we like it. There's a new nice interval in that femoral neck area. Just to show you on CT, 3D CT, how it looks like, you have here a combined problem. This is an Olympic champion, by the way, in hurdles. You have the cam impingement, you have the combined pincer. When you remove it, you have the removal of, or the flattening of that area in a nice interval again, and you have the pincer that has been removed. Now, pincer happens to occur, cam happens to occur more in the male young population, while pincer tends to happen more in the female middle-aged population. I will not state specifically what type of age that must be. Middle age is fine for me. But in about 86% of the cases, you have a combination of pincer and cam impingement. So this is the peripheral compartment. You saw some pictures of the bumps. This is how we do it. We just position well our portals. Our visualization is good. And then step by step, first of all, localizing very well where you are and how your rotational movement of your hip is. Little by little, you do your bumpectomy. And then you will see here. So you will have here the femoral neck coming down. You have the femoral head more above. I think the light might be a little too high. But anyway, with our shaver and our raspers, we can nicely recreate the interval. Here you see the cartilage coming towards the femoral head, and then the bumpectomy over the neck. So what's our rehabilitation? We tend to use crutches for 2 weeks, and the first 6 weeks we're quite conservative in our flexion and endorotation. After these 6 weeks, we go much faster with power training, and we have sports resumption in 3 months. Of course, this is very sport specific. I mean, running would be advised already after 2 months. Cycling after 2 months, running after 3 months, and football between 4.5 to 6 months. So it's very sport specific. Now, having the opportunity to follow this conference, I was astonished to see how during this 2 days conference, how moderate our techniques is being described regarding outcome scores, to be honest. It's very different to our orthopedic results, or when you talk with colleagues who do a lot of them, since we do have the feeling that we're changing things for our athletes. So, or we are the crooked surgeons, or we have to reflect on the outcome scores. I think this is very important in the future, because we have to know where we're going to. Now, we had the central compartment, we had the peripheral compartment. But nowadays we have also the two other compartments of the hip, the extra-articular ones, which are the lateral ones and the hamstring side, so the fourth compartment. Now we can address the psoas, we can address Trochanter Bursitis. We have this fantastic, nice athlete with snapping hip. We have gluteal tears, piriformis hypertrophy. We address this through the lateral compartment, but you now also can treat the fourth compartment. And I take the occasion just to highlight a little bit these more newer techniques. Now, the Trochanter Bursitis, in my opinion and my clinical experience, quite frequent. Not frequent to operate, but it's a solution like many others. Now, we open the fascia lata here. Once it's open, through the lateral compartment with the patient sideways positioned, we open the fascia lata, and then you start to see the hypertrophy of the bursa itself, full of inflammation and elastine, as you will see. Very thickened, very chronically inflamed. Okay. Then, once we're there, we clean up the bursa itself, which look, here you see a lot of inflammation around that insertion. And once you remove it, you really clean up that area. And there you start to see the shiny fibers of the vastus lateralis. And by finishing it, you just remove the bursa itself, the chronic mechanically and inflammatory problems. And that's how it looks like after debridement. You see the muscles of the gluteus appearing on the right side. So, the fourth compartment. This is the compartment of the hamstring problems, also of the ischiadicus problems and the chronic hamstring tears. Just for your information, how we as hip arthroscopists also try to extend our boundaries and see if we can have added value there. Now, of course, this fourth compartment is kind of new for us. We have to be very comfortable with the anatomy, but the new data on the hamstrings that is also very productive here in Aspetar helps us a lot with this. Now, the hamstring imaging in MRI is very clear, so that can help us a lot. But just to give you an information, they can present in many ways. You have the chronic Popeye biceps femoris ruptures that are there in our athletes a long time. You have the housewives who go skiing and fall flat. But you also have the athletes with the very severe hamstring problems, and mainly the proximal ones. We tend to treat them nowadays arthroscopically. So how do we do that? We give a good preoperative setup. We have to know very well where you are. You have the tuber ischiadicum, the trochanter area, and here you have the rupture of the proximal avulsion of the hamstring. It's a little bit, you'll see it later a little bit better, but you see there you have it. That's the avulsion itself, and you see it doesn't hang on the bone anymore. Then, when we clean it up a little bit, here on the back side you can see the ischiadic nerve. So it's not always a fun area to work in, but it's challenging for sure. Yeah. Then, what we do is we go to the tuber ischiadicum, we clean it up with our burr, but the burr doesn't penetrate enough in the bone to have good bleeding and a good attachment of the newly readdressed tendon on the bone. So we also give microfracture in that area in order to have good bleeding around the reconstruction, the repair that you want to do. So after this microfracture, we put our anchors that we like so much to reattach. So we drill, we tap, and we put the anchor inside. Then, I think this is the one. Then we put all the sutures around the proximal side of the hamstring that was ruptured. And then we make the sutures ready. We push them towards the bone that has that bleeding area now. And this is the end where you can see the hamstring avulsion itself reattached to the tuber ischiadicum that you can see around it. with the nuts, and this is the muscle itself. Okay, what about the fourth compartment? Last word about that. You also have chronic hamstring injuries where you have the ischiatic nerve really into a cloth of fibrosis together with the hamstring fibers. And when you have that, we have with this fourth compartment now the opportunity to release the fibrosis of the hamstrings here with the ischiatic nerve there. So just to show you how we do it, I will also, for time measures, go a little faster. So here you will see my probe will go into that area of fibrosis in order to release it well. So here we go into it, and that gives the relaxation. But of course, this is primum non nocere. We have to make sure that our athletes are well treated and we don't take too many risks to help them. Okay. Now what about the complications? 2 more minutes. Of course, you have the neuropraxia, you have the skin necrosis, you have the instrument breakage, the infection, the femoral neck fractures. In my opinion, the neuropraxia is the most frequent one. And then you always have not the husband or the patient itself calling, but his wife, if still everything, if no nerves have been hit on the pedentic area. So that's always something we have to address very cautiously, but when you have it, and it's between 7 and 17% of cases, depending on the padding that you do, you just have to inform them well. Yeah. Now, let's not get too carried away. The fourth compartment was that, but how to find our way in the hip. It's a keyhole surgery. It's all quite minimal invasive, and you have big muscles around it. So you search for anatomical landmarks. One of them is the zona orbicularis, that we know then exactly where we are. The other one, unlike in the knee where plicas are things we don't like, in the hip it's something fantastic to show you where exactly you are when you're moving around with your keyhole cameras. The fovea itself is of course something that gives us a good idea on the central position of the acetabulum, and the limbus to show you the difference between the central and the peripheral compartment. 2 more slides showing that how we position the patient. It's a setup in OR that really needs a specialized staff, because the arthroscopy is just like one another, although the camera angles are different. But if your staff is really into it and highly enthusiastic about it, it's surgery that is being done now more and more in a good fashion. The padding is very important. We use posts and a perineal protection. And the anesthesiology also needs to give good relaxation in order to have a good access to the central compartment. And the traction time has, of course, to be limited. Now, the leg itself is abducted, in traction supine or lateral. You can choose. Mostly we use supine, but many good surgeons also, especially one person in London uses it in a lateral way, which shows also very highly qualified results. We use the X-ray beam. We put in little flexion to relax a little bit the anterior capsule to have a better visualization. We slightly internally rotate the foot, although more and more we don't use it anymore. And the other leg is just to make sure the patient doesn't fall from the table in slight stabilization. Now, in groin pain related pathology, early detection is the key in order to avoid degenerative changes towards further pathology, mainly in our young and active population. And this requires the multidisciplinary approach that I really am grateful to, that I can work in a setting like this. Thank you very much.